So Dr. Tremmel and I are going to tag team a little bit today. Many of you have seen me talk before, either on video or live stream from other walks. But I am not going to assume that you know that. So some of this material may have seen before, but we don't want to leave somebody behind who hasn't been to one of these or doesn't know anything about SCAD. So we'll talk a little bit about what SCAD is. But the biggest thing we want to share is what's coming in the future. So what has happened in the past 6 or 8 months? What are some of the new findings, as well as some of the new research and partnerships that are happening as a result of greater awareness of SCAD across the country? And we're really excited about that. So we'll start, I guess, a little bit. So that's Mayo. I didn't have a picture of Stanford to stick in there. It's beautiful, and it never gets snow. Right. But I do always like to start any talk almost with a PSA, a public service announcement, about what the signs and symptoms of a heart attack are. Because SCAD is a heart attack. You all know that. And we could do, and many people knew they were having a heart attack. Honestly, they said this had to be a heart attack, but others waited. And I think one of the things we can do, both to save your lives, those who are survivors, as well as other people in your community, is knowing that chest pain is the most common symptom in men and in women. Although women may have more symptoms and may have some of the other sort of unusual symptoms or different locations or more shortness of breath. So anytime you have these symptoms, I think the other thing that many of you may have experienced is it isn't necessarily like that Hollywood heart attack. It isn't that, for some it may be, where you clutch your chest and it's there. Others, the symptoms may come on gradually or wax and wane. And I think it's important not to ignore just because it gets better for a little bit. So what do you do if you have a constellation of these symptoms? Thank you. Dial 911 for those of you, because too many people call a relative, a neighbor, a family member, or drive themselves, which does not allow the same life-saving approach. So I did share this story in May in Chicago, and it was very fresh then, and I didn't want to discourage those of you who feel like we've gone farther, but I think it's the same reason that I share about what heart attack symptoms. So this, I call it the tale of two sisters. So there was this, she was sitting in my office with her sister. Her sister told me, oh yeah, I had SCAD. I was treated up in Minneapolis. I had amazing care. They diagnosed me. They treated me properly. So the sister that I had a very different experience with her SCAD. So 10 days after her sister had SCAD, and this is a lawyer, she was in a more rural area, but she'd gone in with heart attack symptoms. She had an elevated troponin. She did have some risk factors for heart disease. She was also a very anxious person, and I think there are reasons people are anxious when they are having a heart attack. She told the doctors, my sister had SCAD 10 days ago. Could this be similar? This is kind of like, she had her troponin elevated, and she was sent out of the ED, and she had a stress test the next day, and that was negative, which it can be because the artery can open and close during the time of SCAD. She continued to have really bad pain, so she was put on gabapentin or Lyrica, which is a drug for chronic pain, not for heart attacks. So she continued. Her family encouraged her now to go back to her internist. Her internist listened to her, and he said, well, but the emergency department said you aren't having a heart attack. The cardiologist said you weren't, and I'm just going to check another troponin. And now it was about 10 times what it had been when it was in the hospital. So she was having a STEMI. A STEMI is the most severe type of heart attack. And even after he sent her to the hospital, she was still not given, because, think about this, many of you in this room do not look like heart attack patients. So there is this unconscious bias that providers have, that they're thinking, I'm not seeing evidence, but I can't believe that this young person is having it. So she actually didn't go to the cath lab that day. She did. She had occluded her LAD, which is the main artery down the front of the heart, and so she did get a stent, but she actually suffered some fairly significant long-term heart damage. So this is why we collectively do what we do, because it's an issue that probably multiple issues. SCAD is uncommon. This woman didn't go to an academic medical center. She was a young, healthy-looking woman, and they didn't make that connection. So you can help by getting the word out about making those connections as well. So SCAD's different. You all know that. And we have to manage it differently. And that's what a lot of our research has been about, seeing where we want to treat patients exactly the same or diagnose them. And one thing I would say, since most present as heart attacks, the troponin, which is the sort of the best blood test, that's one that even if that patient looks really healthy and they're having chest pain and their troponin's elevated, they should be evaluated for a heart attack. It's not always a heart attack. And so I think the other thing is, now that we've been here for several years, there were tutus even back then, that it's kind of our story too. So there's with all the coats in Chicago, and Ellen. I mean, the outfits get better. I have to have her in the corner. Thank you, Ellen. And this is some of my Mayo team members who've either been here or gone to the, including Dr. Tweet. Some of you asked because you've seen it. This pointer doesn't work. That's her carrying the child in the pouring rain. That's me pushing the other 2 children. It's quite a teamwork that we've got going. And there's her 2 older ones there. So the SCAT story has become part of the work that we really care about. We care about you, we care about the science, we care about finding answers. I like to tell the story of how it starts because it's the story of patients. It's the story of patients who said, we think SCAD's way more common than you doctors are telling us. All the doctors tell us nobody else has it, but here we've gotten together on an online community and there's 70 of us, and you doctors are saying that I won't ever meet anybody else and they haven't ever seen anything. That gets doctor to think about, because those 2 things don't really fit. So in this past year, we've been on NBC Nightly News. We've been in WebMD, both online and in print. There's Ellen again. She got a makeup job for that. But that goes in a lot of doctors' offices, and that's you guys. Been on the Today Show, been on Women's Day, been in Prevention Magazine. That's Danielle Denline. Been on Dr. Oz. It was her dream. She'd been in the audience like 4 or 5 times, and she wanted to tell her SCAD story with Dr. Oz. So I think one of the things that what you collectively have done is helped us elevate this, so people, at least, not everyone, will say, I've never heard of it. We've been spreading the word at medical conferences. There's Dr. Tweet again. The thing I liked best, and the reason I have pictures here, is so she was presenting about postpartum and pregnancy, and those 2 moderators who were interventionalists, because it was an interventional track, they actually said to her, and during the question they said, well, you know, it's common knowledge, it's well known that you don't want to intervene, you want to treat SCAD patients completely different in the cath lab. So I'm just sitting in the audience thinking that's really good, because that only came out in the past 5 or 6 years. So I'm thrilled that these 2 young interventionalists both say it's well known. That was good. But I was also wondering how she was going to answer it, because she was first author on the paper that actually showed that, and she did a great job. But so what is SCAD? Most of you in this room know, but I want to share. So this is a little animation of atherosclerosis. This isn't SCAD. This is fast forward over decades, where you build up plaque filled with gooky stuff, that medical term, and the plaque ruptures, and a blood clot forms over that to sort of heal and seal the artery, blocking flow. So that's what an atherosclerotic heart attack, and that takes years to build up. So SCAD can take literally seconds to minutes, and it's when there's a tear in the artery, and sometimes just a split in the artery, but you see that's a healthy lining, and that flap can occlude the artery. You can have a complicated flap, and you can see that sometimes we call that an intramural hematoma, where it forms and it kind of squishes the artery, another important medical term. So one of the reasons SCAD was so under-recognized was because we were taught that's a normal artery, and we were taught, and I do include Dr. Tremmel, and she's considerably younger than I am, but I'm presuming she was taught that that's what we look for. We looked for the flap when we saw. What we've learned is a lot of people have this intramural hematoma. They don't have a flap, and that can look, if you do an angiogram, it could look just like the atherosclerotic plaque. So we were missing them. That's why when we say, I have a lot of times, is SCAD more common now? We're not really sure, but we're for sure that we've missed some, because we, even at Mayo Clinic, where we know a lot, we re-diagnose or find out that that we had missed it previously. We do have some better tools. So if you can see that the intramural hematoma with the intravascular ultrasound and OCT, optical coherence tomography, can show this intramural hematoma there much better. So if we have a question, we can do that. But I think what's happened is that our interventionalists, once you see it, it's sort of a pattern recognition. You don't have to do these advanced tests every time. Here's just a movie. So you see the, I'm going to let it run a few times, but you see that there is, the dark spot that's where the blood is. And then you can see that that dark spot, that's the artery, and it gets real narrowed down. And as you watch it, you can see that there's a different little line and then blood around it. So this is the dissection here. And that circle, that's the catheter. So it's kind of cool. So it is an atherosclerosis. The reason we know that, it happens in younger people, predominantly women. People don't have risk factors, and different associated risk factors, which we'll talk about. I think the other thing is, I've stopped using the word rare. Sometimes it slips out, because relative to all heart attacks, it's still pretty darn uncommon. But if we look at the demographics, particularly younger women, women under 50, it may be the #1 cause of heart attacks. It's certainly the #1 cause of heart attacks in women who are pregnant or recently given birth. Oh yeah, I had an aunt, she had a heart attack when she was 40. Dad had an aneurysm. So there's something there that may be a common abnormality of blood pressure. So I still wanted to talk about our research. I'm going to have Dr. Tremmel talk about her current and our collaborative research, but to understand what we're doing at Mayo, it is a registry, and a registry is where we collect data, both past data, and also we can do a prospective, meaning we keep collecting it. But it isn't like a clinical trial where we then find something and we try to intervene on it. And that's important because registries can tell us a lot, but they can't really necessarily tell us what's the best treatment, or because we're not comparing head to head. Our goal, ultimately, would be to leverage the questions that are raised by a registry to a clinical trial, where we have a hypothesis that there's a good treatment and we can do that. And the only way we're going to do that is through not just Mayo doing the research, but lots of us getting together, because it's still uncommon enough to be able to do that from a scientific standpoint. So what registries can tell us is they can give us a little bit of what we call the natural history of so how does a SCAD patient do over years, because we can ask you those questions and look at medical records. But we can't answer the questions about which treatment is best. We can hypothesize. It's different from a clinical trial, as I said, because we're not actually doing anything to somebody and seeing how it turns out. That's like a clinical trial. And another frequent question is, I'm in a registry. Well, in most registries, once you sign up and you consent and you're part of that, then people will look at your data, they'll look at it and compare it to other people's data, but you won't necessarily get regular updates from the research site. We're always can answer those questions. A few of you gave me your name and birth date because you said you hadn't heard if you were in the research or had some questions about your status. I am happy to take those back to Jill Boyum, our study coordinator, and she can get in touch with you. The other thing is, I always come to these and they said, yeah, I lost my packet. I have one. Come up to me afterwards. If you lost your packet, didn't want to do it at the time, but have reconsidered, I'd be happy to do that. The other part of our research is the DNA Biobank, and for those of you, you can get a little swab from your cheek, a little saliva, and your parents can too. And the idea is, because we know there may be some familial aspect of this, that if we have your parents, and since many of SCAD patients are young and their parents are living, if we have the parents and the patient, then we can learn something from that. And the results for a research trial don't get sent to you. That's very different than if you're in active trial. So, but the way results get forward is published in medical journals. That's the way we doctors communicate to each other, but also by coming and sharing at venues like this, so you can see what we may not be quite ready to publish, but what we can share with you that may be helpful. When we get funding to run the DNA, and there was a finding that was relative to you, we would share that with you. But I'll get to that later, but we haven't gotten full funding for running all the DNA. So just a status check. As you know, we started with an N of 12 patients, SCAD patients. That was our first cohort, and we've now enrolled over 850 people. That's consented. Yeah, we think it's cool. We have about 100 right now in process, and that means we don't have enough of the medical records to be able to confirm the diagnosis, or we've got the medical records, but my interventional colleagues haven't had time to sit down and look at them. So there's a little bit of a backlog, and that's always the case. So that's the in process. And so sometimes if you haven't heard from us, it's because we're missing something. And as I've heard, somebody said, well, if I knew that you were missing something and you couldn't get it from my hospital, I'll walk in and get it. We'd love that. It'd save us some time. So as you know, we ask you to tell about your SCAD experience. That's one unique part of this. Since you don't have to come to Mayo to be a part of this, we don't get the benefit of sitting down with you in the office and putting all the pieces together by asking you follow-up questions. So your narrative can help weave the medical records together. And then, as you know, many of you have received follow-up questionnaires over time where we did develop a hypothesis. We realized we asked that question, we got some interesting answers, but we didn't ask the right questions or enough questions. So we've been sending those out, and we appreciate those of you who continue to participate and update us. This is most of our team, not all of it. That, as you can see, that's when Deb McGarry was there presenting the check from SCAD Research Inc. This is where the money that you have given has really helped us, and that's sort of our full team. Well, not even our full team. So I told you that the way we communicate and the way practice is changed is by researchers publishing in journals, being read by others, being replicated by others. And that's why it's important that we have other people doing research. We are not the only ones. Stanford, Mass General, Vancouver, because when we see something and maybe we're a little bit surprised by it, maybe we think that's not what we thought, but then another group looks at it and they find the same thing, that makes it all the more strong. So that's kind of where the research comes. So we're real excited because I shared from starting with kind of nothing, there's actually going to be both a European and an American Heart Association scientific statement. It's under review. I can't tell you content. It's based only on what has been published. So much of it you already know, but these are in big venues because they are in the major journals of both the European Cardiology Society and American Heart Association journal, which is read by cardiologists. So that's good because it gets it out there, and instead of saying, I never heard of that, they can't say they've never heard of it. You can refer them to this paper. So we've learned a lot more about imaging. I've shown you some of that. I think one thing that's kind of promising is using CT coronary angiography, not for the initial diagnosis of SCAD, but in follow-up, so there don't need to be as many angiograms, or when people have symptoms, to be able to not have to go in and do an intervention all the time. We know that, so this was a study that looked at the CT compared to angiogram. We've still got a ways to go in that technology because the angiogram is the gold standard. So I don't want anybody to walk out of here and say, oh, you know, I'm somehow afraid to have another angiogram, or can I have a CT? Sometimes this is the only way, and most of the times it's the only way, but we're looking for ways that would be less invasive that we can make diagnoses. There's the OCT. These are just a few of the papers. This was just a case report, but it was kind of nice because it gets to the fact that we know that some people have a trigger of emotional or physical stress prior to this. And I think the other thing that we felt has been very important is to get the literature not just to cardiologists, but to internists, to emergency room doctors. So this was published in an emergency medicine journal. And so we've had papers that are now published in OB/GYN journals, because if you're going to have physicians who care for a lot of women, we want them to be up to date as well. Many of you, and I share this story, so this is under review, but this was a poster that one of our women's health fellows actually did, is The very first research agenda that came from patients was, gosh, are migraines more common in SCAD patients? And certainly in the clinical practice, it seemed like a lot of the patients had migraines. Both are vascular issues. So we actually we now have enough folks in our registry, and it is considerably more common. We don't have a control population. That gets back to, this is a registry. This isn't a clinical trial with matched individuals. But compared to the same general age of women, 42% of SCAD patients had a history of migraines, as compared to those without. So there were some other differences as well. And people with migraines are more likely to have recurrent chest pain after SCAD than those who don't have migraines. So this is, again, this is one of those we don't know why, but it makes us think so that we maybe can look at other things that will help us down the line or design something. And this was in an OB journal, their biggest journal. So that was important, and it had a first author. And so we work with folks in all of our other departments. I think the important thing is even having a definition of what peripartum SCAD is. There were people that were being called peripartum at 10 months after giving birth. And what we found is that the vast majority, this is in weeks, and that red bar, this is among pregnancy-associated SCAD, and the red bar is in the first week postpartum. That's by far the most common time. So again, research, once you get enough numbers, you can start seeing things. Some people have wondered why postpartum. Early on, I thought, well, we knew that heavy physical labor, maybe it was the labor that may have made it a higher risk in the peripartum period. But there's an awful lot of other things going on, hormonal and other, and many of the women had planned C-sections, so they never went through labor who had peripartum. So it clearly wasn't, it may have contributed, but that wasn't the sole reason. And we have a number of people who've described chest pain or having SCAD while they were breastfeeding. So the whole hormonal flux aspect is probably more of an issue than it is the labor, the pregnancy, estrogen alone, or anything. So again, hypothesis generating, but one that now we have just, looked at some of these things, we can look further. So in terms of pregnancy-associated SCAD, that's been a recent publication. It tends to be older mothers. 35 isn't old, but that's old for a first baby, or older. I had my first child 3 days before I turned 30, and if I'd waited 3 more days, I would have been called an elderly primip. That's the ugly term that they use. So most had multiple pregnancies and deliveries, and as I said, 11% of the patients had some symptoms around lactation. So again, the oxytocin or something. These are important. Once we pick up the patterns, then we can take it to the next level and look at it. All right, this is just a transition slide. So I do want to talk about tortuosity, because tortuosity, that's a funny word. We all know what it means, but think about Lombard Street, think about things that go back and forth. So one of the things we just anecdotally observed is, as we were reviewing these thousands of SCAD angiograms, is SCAD patients tended to have more tortuous arteries. We didn't know if that was just an anecdote, or whether compared to other groups. And what we found was, yes, SCAD, not everyone has tortuosity, but it is somewhat of a marker and makes you look a little harder at that artery to see what the cause of the heart attack was. And here's just a cartoon to kind of help you. So coronary arteries aren't straight, but they kind of curve, and we'll see some that actually have almost curlicues. So in patients who have a recurrence, it is more likely to occur in one of those really tortuous curlicue areas. So we don't know exactly what that means. Is there fibromuscular dysplasia? Is this a sign of weakness or uncoupling? But it may be that this tortuosity means something, and we're continuing to look at that. And so here's the tortuosity, a patient with SCAD from our study, and one that's more of a normal angiogram. Yep. So treatment, that's one of the things that the research from across has sort of identified as perhaps needing to be different, and why making the right diagnosis right up front. Because this is what our guidelines still currently say, is that somebody's coming in with a heart attack, you got to get them to the cath lab. If their artery's closed, you put a stent in it, you put antiplatelets, give them a statin. And fortunately, in 2016, there was a heart disease guideline for women. It was a scientific statement, which is a little softer than a guideline, but it actually had several paragraphs differentiating SCAD as a heart attack. So it consolidated the research that many of the SCAD researchers had been doing, but the landmark thing is it wasn't just literally a sentence. It was more than a paragraph. It was several paragraphs, almost a page, to talk about what had been new. And this, again, these scientific statements are read by many physicians. And, you know, I say that a lot, but many of you say, why didn't my doctor know about this? Or why do I walk in and have to explain my diagnosis and explain, you know, teach my doctors every time? We're trying to get the word out. So there are treatments. There's stent. There's a cartoon of a bypass graft. There's a lot of different treatments that have been reported as being effective for SCAD. One of the things that we identified is that the success rate for doing an intervention, putting a stent, opening an artery for a regular heart attack, atherosclerotic heart attack, is probably in your hands over 95%. But what we found is among many SCAD patients, it was around 60 to 70%. And it was because sometimes when people would go in and do the angiogram, it would actually make things worse or cause side effects or tears in the artery. And this is one. This is not from Mayo, but I think it demonstrates it for those. It may be kind of bright, but so A is a SCAD-affected artery, and they put a nice stent, open it up really, but what they do is they push that intramural hematoma way back in the artery, put another stent in, and now there's it's narrowed back farther and all the way back. So what happens is that SCAD actually got a bit worse. So we still have to stent some of these arteries because if the artery's blocked and the person is having chest discomfort, but if they're doing really well, we now feel more comfortable leaving that, maybe that trickle, because it may heal. And we know that arteries heal after SCAD. They don't heal after that atherosclerotic plaque. So here's an artery that did heal. So what we're encouraging our colleagues to do is to, when they see a young woman, young man, no risk factors, perhaps they had an emotional, that they had a heart attack, is to take a second look at that artery. One, recognize that they're having a heart attack, but when they do the angiogram, making sure they don't just assume it's atherosclerosis, because it may alter the way they treat. So I want to talk a little bit about causes, because that's kind of a holy grail. Because first you find out what is the cause, and then you want to find out how you treat that cause. That's important. So I changed the size of these bubbles as we get more data, and you can see the fibromuscular dysplasia has gotten considerably bigger. Fibromuscular dysplasia, or FMD, is an abnormality of the middle layer of the blood vessels, the muscular layer. And it was sort of an anecdotal finding that came from both a Vancouver group. So Jackie saw up there, she treats a lot of FMD patients, and she said, you know, my FMD patients are having more SCAD. And we were looking at angiograms of SCAD patients, and we found that half of them that had an angiogram of their femoral artery had FMD. So that's coming at it from two different ways, which means it's probably real. We're not calling it a cause. That's a higher bar, but it's clearly associated, and probably 50+% of individuals with SCAD have fibromuscular dysplasia. We've got the pregnancy and hormonal. The collagen or genetic defect should actually be much, much smaller if we were going to do this for scale, because probably less than 5% of individuals have an identifiable collagen defect. And then we still have a pretty big circle of other where they have none of these things. So that's where we would like to spend some time better understanding. And then between that, we feel like there's a vulnerable patient. Maybe you're pregnant. Maybe you have fibromuscular dysplasia, but you've done fine for 50 years or for 40 years. So in many people, you've got that underlying condition, and maybe a hormonal stress, a shear stress, meaning extreme emotion, or physical activity was the trigger. That about 30+% of individuals will say, it was the most stressful time in my life, or my house burned down, or I was climbing Mount Everest, or something like that. We have to be really careful with the trigger thing, though, because if you have something bad happen to you, you spend a whole lot more time than usual thinking about what was happening around those days. Most people don't have an identifiable trigger, but that's kind of where we're thinking right now. That's a cartoon of FMD. Some of these are in the little pamphlet, if you want to go share that with your relatives, because these pictures are in that. And there it is reconstructed in a CT angiogram, and that's an angiogram over on the left. So that's what fibromuscular dysplasia looks like. They call it the string of beads. And you can see that's a fairly significant case, but you can kind of see how it looks almost like pearls in the artery. So what we started, when we found the first few FMD cases, we started looking prospectively and screening folks, and found that over 50% had FMD after SCAD, and then another 20% or so had other abnormalities like aneurysms or dissections in other arteries without FMD. And so we are recommending that SCAD patients have some screening of their blood vessels for two reasons. One, because we want to make sure they don't have an aneurysm or something else that needs to be treated or monitored. But two, if they do have FMD, they may have some other screening down the road, and it may give an answer. One question that I get, and I think Ellen asked this to me at the time, why should I, if it's not going to make any difference, and most of the FMD we find is very mild and does not require treatment, why should I know? That's a great question. That said, that means that you may have if you have FMD, higher risk for vascular issues elsewhere. And at least anecdotally, a couple of folks, SCAD survivors, subsequently had a symptom that turned out to be vascular in another vascular bed. So some of it's just knowing what to tell the doctor. But the other part is some people just feel like they need to know. And this is a group assembled here. A lot of you, what I have heard is needing to know. But if you had to say, if I had to say what's the minimum, I would be getting brain, so that, because there is a somewhat increased risk of aneurysms in patients with FMD. The current FMD guidelines do say that at the new diagnosis of FMD, one should have a scan from here to pelvis. So we kind of follow that, because at least 50% of our patients have FMD. These are just more pictures. So that's what that slide says. So most of the FMD that we are finding is quite mild. We don't need to do anything. The FMD experts would say, well, we're maybe another scan in 5 years if there's nothing there but just minor changes. But obviously, if we find an aneurysm or a dissection somewhere else, we may need to have more frequent episodes. So we engage a bunch of folks for FMD because, doctors, we divide up the body so that we've got the cerebro people, and they do the neck up, and then we've got vascular medicine, and they do. But that will be different at each of your hospitals. All right. For those of you who are the first year, those were the custom M&Ms that Ellen got for her birthday. So many of you, in fact, from the day one when this research was started, is what about my family members, particularly my children? Can I pass this on to them? What's their risk? And I think we don't have that answer yet. There are familial cases, but they are really uncommon in the bigger scheme of things. So remember, we've got 800 people, over 850, and there's about 12, 15 families out of that have had. And it's different forms of inheritance. So sisters, like the one I started with, mother-daughter, aunt-niece. And we have done whole exome sequencing on a group of SCAD, and that's and the families, the parents, and what we found is we can pretty confidently say there is not a SCAD gene. There's not going to be a test that will explain all. There's not an FMD gene, and so what we're going to need to do is dig deeper. And how we do that is with both whole exome sequencing, which is taking every single exome in a person's DNA and analyzing it, which is fairly costly and takes a fair amount of time. And we currently don't have that funding. We're looking for it with my colleague, Dr. Olson. Jeannie Teese and Tim Olson have been doing this work. But the other is now we never thought we would be able to do genome-wide association testing because we never imagined, you need a minimum size of about 500 people. We never thought we would have 500 participants, and we now have that. So we're working through GWAS, is how we say that. So we've got the biobank. We're looking to connect the biological mechanisms with the genetic mechanisms. And so since just since April, which is when we reported on this, there have been 43 new study participants. We've gotten DNA, so that's just since the Naperville SCAD. So we've got a lot of folks, and we're working through them. And we've got a few worldwide scattered around. So I'm just going to skip. I thought I hid these ones. So I already told you that. No SCAD gene. And the SCAD patients don't have those other genes like Marfan's and Ehlers-Danlos. I mean, there's a few of them done, but there isn't a direct connection. So genetic testing as it currently stands in 2017 is not very helpful for SCAD, I will just say. I'm just going to pop through these because I didn't mean to show them. All right. Puppy dog. So just talking very briefly on the practice aspect, one of the things we've learned is once you get some, do the research, we at Mayo were missing things. We look back, we did and we keep great records. We look back and we on average from 1985 to 2010, we're seeing about 10 to 12 SCAD patients per year. That's what we thought we were seeing. Now we were missing a bunch of other ones, we're sure, but that's how many had a diagnosis of SCAD in their medical record. Well, now we're seeing at least that many every month. So that helps accelerate the research because when you actually have the patient that you can talk to them and you can do the test, so there may be other directions. So it's complementary to that. It also gives us as the clinicians a lot of experience. So I wanted to talk about, because I always get questions from this group about some of these questions, and I actually might have Dr. Tremmel step up because she's got a lot of experience in some of these, but a lot of people have chest pain after SCAD. Estimated probably 50 to 60% do. That's higher than people who have atherosclerotic chest pain, atherosclerotic heart attacks. Some of it is clearly non-cardiac. You know, it's a hyper-awareness of one's body. Because if you've been in the hospital for the nurse comes in and asks you to rate your pain every 5 minutes, and so you get really attuned to your body. And that part is easy. So somebody comes in and they says, I've got this sharp pain right here in my elbow, and it comes on and it lasts for seconds. I'm pretty confident that's not cardiac. But a lot of folks have things that are reminiscent of their SCAD, or at least we need to evaluate. And so that's something that if you're a SCAD patient, you've probably experienced it. It can be quite frightening, and it's probably caused by some different things. So we always have to make sure there isn't a new SCAD or a new blockage. But the thing that our experience is people, as their artery is healing, may have some vasomotion. So they have spasm of that artery. So instead of the artery relaxing and letting blood through, it may not be. At random times, maybe at night, or when people are sitting at rest or dinner, they pass a stress test. So some people will respond to nitroglycerin or other things even when they don't have a blockage. And I think this will be a helpful thing to get that practice, which is not super scientific at this, out into the general cardiology population. Because what I've heard is some people have passed a stress test, so they said, oh, you're fine. And when you may not have a blockage, but you may not be truly fine. So I can't emphasize rehab enough. You know, when you heard Danielle talk this morning as she was the youngest person and they had 2-pound weights, first I would advocate that cardiac rehab needs to be individualized. That's the national guideline. So, 20-year-olds should be able to lift more than 2-pound weights. I would encourage rehab, but they don't have a lot of experience with younger folks. But it's not getting back to exercise, it's getting back to your life. So anytime you hear of a SCAD patient who either declines rehab or doesn't go because they think they don't need it or their doctor doesn't refer them to it, encourage them to go or seek another doctor or opinion. We usually recommend aspirin after SCAD even if somebody doesn't get a stent. We don't have really good hard data. We don't think aspirin prevents another SCAD, but we think that if you have a heart attack, it will limit the size of the heart attack if you've got aspirin on board. That's why people chew aspirin at the time of their heart attacks. We also, as you saw, statins were used routinely. I'm a statin fan. I use it in all my atherosclerotic patients, and I spend a lot of time convincing people, helping them get through statin intolerance. But there does not appear to be any benefit for statin in terms of reducing recurrent risk of SCAD. So if you have really high cholesterol, you should probably be on a statin because you want to prevent that atherosclerosis down the road. But it probably isn't something that's knee-jerk. And And we were the first to sort of look at that and evaluate it, and Dr. Saw just published within the past couple of weeks kind of confirming that statins aren't harmful, but they don't help prevent recurrent SCAD. So what are we going to see more of? Well, we're hoping with guidelines, scientific statements, more publications from all of the researchers that there'll be better diagnoses and better treatment. And we're continuing to look at these. I think one thing is I get asked all the time, how common is SCAD? Until, Stanford, Vancouver, Mayo, Mass General, we are referral medical centers. So we're going to be seeing a higher number. If you just have a SCAD in a community hospital and you do great, we're never going to hear about it. So it's hard to know what the prevalence is. And obviously we don't always know. We don't have included in our study people who didn't survive SCAD or were never diagnosed it. Maybe they were never diagnosed with a heart attack. So I think having some better, that will be helpful to know, because I think we can engage our colleagues in terms of getting better treatment. All right, so these are the authors of the scientific statement. Here's a few of their photos, and you can see that both, that we've got folks from all over, well, including all over the world in England. So I'm going to stop there and ask Dr. Tremmel to come up, because she's been working on some exciting things that I think you'll like, because it's pulling a lot of us together who are seeing various groups of patients to try to start working together in a more cohesive way. So make sure you step over. No, step over.
Fantastic overview, and you got all the details there. I'm going to do a little bit of a more informal discussion. Actually, I'm one of the reviewers on your little paper there, so it is. I'm a little late getting it done, but so my name's Jennifer Tremmel, and I'm an interventional cardiologist. So I'm the person that you meet when you first come in with your heart attack. Interestingly, as you may or may not know, most interventional cardiologists are men, and we were just talking about the
96% are men.
96% are men, yes. So
it's a rare word.
So yeah, I'm kind of like the man with SCAD, I think, right? And my background is, I wouldn't have normally mentioned this, but I met so many Midwesterners. My background is I'm from Iowa, and I was born in Iowa City, and Iowa just beat Iowa State. Go Hawks. I know there's Iowa State people. We like Iowa State people too. And I did my training out east, and then I went to Stanford for my fellowship. And I did a fellowship in preventive cardiology as well as interventional cardiology. And when I got done with all my training, I kind of had this broad training, and I'd done some research in women in the cath lab in terms of bleeding risk and that sort of thing, and got kind of interested in sex differences in cardiovascular disease and what can we learn about women, particularly by looking at men and vice versa. And especially, there's a lot of, I would say, kind of discrepancies in terms of how we treat the two, and this is actually a very ripe topic here with SCAD as well, and we have a lot to learn from the men that have SCAD to give us some insights, I think, about the women. So I was interested in sex differences, and so started our women's heart health program as I was finishing my fellowship in 2007, and so we've been going for 10 years now. I started it with a nurse practitioner at that time, and we just kind of made a website and made some cards and started, and we've grown considerably. And so at Stanford, I still have my nurse practitioner that I had, plus we have a preventive cardiologist, we have two non-invasive cardiologists, we have several nurse practitioners, and we have two psychologists. And the psychology aspect was very important to me, and my background before all this in college was I was a psychology major, and actually my favorite class was a class that looked at kind of the psychological aspects of health. and that they play a role in each other, right? So our psychology certainly affects our health, and our health affects our psychology. And it always seemed to me these were very inseparable, yet in medical school they do a great job of keeping them completely separate. And so this kind of bothered me. And so one of my big goals when I started the Women's Heart Health Program was that we were going to have some sort of integration of psychology as well. And it turned out to be quite challenging to do that because, as you said, all the body parts are separated, and that includes the brain and the psychological part of the brain, not even neurological. And so even at Stanford, there's a psychology department and then there's cardiology, and how do we put all that together? And ultimately what I had to do was hire my own psychologist in cardiovascular medicine, which is kind of a rare thing to have, but very fortunate. So that's kind of my background. With my research, so I look at, like I said, sex differences in cardiovascular disease, and so I have several areas of research. One of them has been bleeding complications in the cath lab, so women are at higher risk of bleeding than men if we go through the groin. And so when I heard about doing procedures through the wrist back in 2007, I thought, wow, this is a brilliant idea. And so went off to learn, and at that time only 1.3% of PCIs or these cath procedures were done through the wrist. And so I made it a mission not only to do that, but to teach others to do that. And at this point, we're above 30%. We're about 35%. So over the course of less than 10 years, which is quite an accomplishment to get interventionalists to change in any way. So it's pretty amazing that we've been able to do that. Another big thing that I do research in, and what my first NIH grant was in, is chest pain in women. But it was about chest pain in women and men that have normal appearing coronary arteries. So their arteries look fine, their stress test is fine, their angiogram's fine, but they have chest pain, and it sounds like regular old chest pain. When they go out and walk or whatever, they get chest discomfort. If they're emotionally stressed, they get chest discomfort. This is a predominantly female problem, but we see men that have it as well. And so we do a lot of extra testing in the cath lab looking for endothelial dysfunction, which has been mentioned today, where the artery squeezes when it should dilate, looking for microvascular dysfunction, which is a small vessel problem, and also looking at what's called myocardial bridging, where people have heart muscle that's over the artery and it's squeezing every time their heart beats. And so, that's been a big area. And then, I think SCAD is obviously another big area for us in terms of trying to figure out what's going on here, and certainly something that is disproportionately affecting our female patients. So as an interventional cardiologist, I go give talks to interventional crowds and with interventionalists, and like I said, it's mostly guys. And so one of my challenges is to educate them, and there's a lot of things they know, but there's a lot of things they don't know. And actually, a lot of the things that I do work in is stuff they don't know. And so I have a real obligation, I feel like, to get the word out. And so chest pain with normal coronaries would be an area that they don't know well. They don't really want to because it's difficult, right? The easiest thing for interventionalists, if you come in and you've got a blockage and I can put a stent in it, easy, everybody's happy, it's great. These other things are more challenging. SCAD would be another area where the interventionalist community has been struggling. And part of it is because there's not somebody out there saying, hey, we need to pay attention to this. Hey, this is important. So that's kind of one of my big missions. And a little kind of insider perspective is that we still have a long ways to go. And it was nice that you said, oh, we're at the poster, and the interventionalist said, oh, everybody knows that. We know for sure that not everybody knows that. And so even at the ACC a year or two ago, I'd given a talk, when can we stop missing this diagnosis, right? And just showing them pictures so that they can get this pattern recognition that was being discussed, because they don't see it. And you guys all know this. I mean, I heard story after story, right? And I hear it in my office, and they don't know what it is. And it's actually very interesting, because if I get a referral of somebody, the two big things I see are, why do I have chest pain and why did I have a heart attack? And so when I get a why did I have a heart attack referral, I look through the record before I go meet the patient, and almost invariably I can read what the interventionalist wrote, and they'll write something very descriptive about how the vessel abruptly tapered, or it was an abnormally small. I remember one person wrote vestigial vessel. They write these descriptions that are SCAD and are that pattern recognition, but they have no clue what it is. And so prior to even walking into meeting this patient, I know what their diagnosis is. Even before I look at their angiogram, I know the diagnosis. And the trick is, how do we get all the other interventionalists to know that, so that when they see it, they know what it is. And a lot of it is simply educating them. And some of it is also moving it up into their brains, right? So if a woman comes in and I'm on call, and we get a STEMI page and they say it's a 40-year-old woman with no cardiac risk factors having a STEMI, what should be the first thing I think of? Yes! Now, if I'd said that to a group of interventionalists, they would all be going, so we're trying to move it up into they shouldn't be thinking about atherosclerosis at all. The chance that the woman has atherosclerosis is incredibly unlikely. Maybe it's spasm, but they should be thinking SCAD first. And so going in with that kind of higher index of suspicion that this could be SCAD is also huge because of how we treat them, right? And we need to be very cautious of the vessels. They are fragile vessels, and just putting catheters in, as you guys know, and some of you may have experienced this, we can make things worse. We flip a catheter into the artery that's not the problem, and it can suddenly dissect. And so knowing that ahead of time is going to make a difference about how this interventionalist approaches the patient. A lot of patients get lucky that they were treated conservatively simply because SCAD maybe affected the distal vessel and made it small. It wasn't because the interventionalists knew that they shouldn't do anything, it's because they thought they couldn't. And that's good, it turns out, because that's the way we typically want these patients to be treated, but it would be nice if they did that because they knew that they shouldn't do anything more because there's decent flow in that vessel. So that's a lot of what I do. In terms of the research that we're doing, I mean, Dr. Hayes has obviously done great work and has been building things for years. And so one of the questions is, how can we all add to that? And so I think one of the things that's very important to me is that there's more work among all the groups, right? There's lots of isolated groups doing work with small, isolated numbers of patients, and that's not going to get us very far. Her database has grown great, but also, as we know, there's data in Vancouver and there's data over in all of these other countries, and I think at some point, how can we actually get all that together, and how will that help us? And so one thing that we put together, and I will actually credit my psychologist for this, because my psychologist met another psychologist in Colorado, and this other psychologist was interested in SCAD patients, and they kind of got together and said, hey, we should do some research together. And in doing that, it was like, oh, well, if you can get your, cardiologist to work with us too, and we start calling other people, and we kind of started to get everybody to work together. And so we have right now, it's a small project, there's not a lot of funds, it's always funding, but looking at peripartum versus not peripartum or pregnancy-associated SCAD, and we already have really good data on this. I think the one thing that this study adds, well, it's actually adding two things, is one, it's an international collaboration. So we have several US sites, we have Canada, we have the UK, we have Paris, so we have groups working together that haven't worked together to kind of start that framework, which is very important. And then we're also adding in this psychosocial component that I think really deserves a lot more attention. The psychologists have done a fantastic job in addressing all the things that happen around having a heart attack and around having SCAD and around having a diagnosis in which you really don't have any certainty and you don't know what's coming next, because it's really frustrating, as you know, in that way. So, the psychologists have SCAD, what do they call it, SCAD workshops, survivor groups that get together, and they're actually trying to figure out how can we do these things when people live so far away, and that's a big challenge too. In California, people travel, I'm sure it's the same for you, right, 3-4 hours, and so to come to a SCAD survivor group every week is just not practical. So trying to put together, how can we telehealth this? Can we do stuff through our devices or something to bring people together to really address these issues? So seeing the psychologist after a SCAD event is pretty much routine that we have everybody do that. People vary. Some people do fine. They actually kind of sail through. They do fine. Other people get full-blown PTSD, and it really needs to be addressed. And if we don't address it, it seems to just kind of make things worse. I think symptoms seem to be worse. And these are all things that will actually be important to research. We have tiny little research studies, but it seems that in meeting with the psychologists and addressing these things, chest pain symptoms get better, anxiety, depression symptoms get better. And so if we can have more of a systematic way of treating people afterwards, so we may be able to improve some of those things. And you mentioned chest pain after these events, and I think it is hard to know what is that, and I think that's another area ripe for research. And some of it, again, if we can do some psychological work and it gets better, then that's telling. But at the same time, one wonders, well, are they having endothelial dysfunction? Are they having some kind of spasm? Are they having microvascular dysfunction? And of course, those are very interesting questions to me since that's research that I do. The challenging part is when I make those diagnoses, I take people to the cath lab and I stick wires and stuff in their arteries. And so actually doing that kind of testing may not be as appealing. Everyone's like, no, it may not. But I think that's, again, another area that we really need to work on. So I was actually going to open with this with saying thank you for letting me be here. It's really been an honor to be here, and thank you, Dr. Hayes, for inviting me, and SCAD Research Inc. for having me, and I look forward to being a part of that group. And it's been great to meet not all of you, but many of you, now several familiar faces. And it is really because of you guys that physicians are paying attention and doing the work that they should be doing. And the louder you are and the more you say we need to do this, the more will get done. So hats off to all of you, and thank you for letting me be here.
So traditionally we do a little Q&A from the audience, and also apparently from, how many are watching online?
We have 24.
Got 24 online, so they can send in questions as well. And just a caution, we can't answer, individual medical questions, but many of you don't be afraid to answer the question, because if you have that question, probably somebody else does too. Oh, we have hands already. We'll go. And I'm going to repeat the question so the people online can hear. So
I know I asked both of you this already, but because we're live, I wanted other people to hear it. I'm still on blood thinners, 2.5 years almost out. And they took me off Prilenta after a year. And then I had a little scarement after, and they put me on plaques. And, it's quality of life issue for me. I'm very athletic and busy.
So the question really is, and what you're talking about is the dual antiplatelet therapy after somebody who gets either has a heart attack or gets a stent. And I'm going to turf this question to Dr. Tremmel, but I think it's an important one because you're on aspirin plus another medication that also thins the blood. So many people, because of SCAD, they're premenopausal, they're still having periods, they're still having, and so the bleeding problems, as you know, as you said, are just greater. And sometimes, and I think this was your question, is your doctor almost turn to you and say, well, you can stay on it as long as you want. And I think that's an abrogation of our responsibility to you as patients to make that without giving it. But maybe you can just give a general thought about, because it seems like it's getting shorter and shorter that we are using dual antiplatelet.
Yeah, so traditionally, well, you've already kind of said the dual antiplatelet therapy, certainly after you get a stent. And so those of you that have gotten a stent, that's the reason you were put on it or should have been put on it. If you have a bare metal stent, then typically you only need that stuff for a month. If you get a drug-eluting stent, nowadays it's 6 months, but if you get it in the setting of a heart attack, then it's typically a year, and even for the bare metal stents. So that's where that comes from. The challenge is SCAD's completely different, just like your slide said. So if you haven't gotten a stent, do you need to be on those drugs? Well, there's no data that you need to be on those drugs. Aspirin in general is still controversial, even in women, just for primary prevention, and bleeding is always a real risk, and not even if you're having periods or whatever. So I'm of the group that I like to take drugs away because I never get to do that. It's like really, and then everybody thinks, oh, doctors love to give drugs, but we actually really love to take drugs away. So I would say if you had a stent and you've gotten through the time period that you needed those drugs, then a very real discussion should happen. Can I stop taking those drugs? If you have a doctor who's not well informed enough, then you may have to somehow have a conversation where they can reach out to somebody else. But I would say if you've been through that period, aspirin and Plavix is not clearly indicated, either one.
So 6 months or a year?
So if you've had a stent and it was done in the setting of a heart attack, which I would expect everybody here, then we would say 1 year to be on both of those drugs.
But if you have no stent?
I personally don't think you need to be on either one.
Yeah.
There's some controversy in the
early on, and I have colleagues, so it's all over the place. But I don't think maybe a month for the dual. I mean, I'm okay with that. But then I'm like you. I said, you can make some theoretical benefits, but there's real harms. And so it's treating ourselves when doctors keep those drugs on.
Yeah, and I mean, women are prone to bleeding, right? So we have more bleeding in the cath lab. We bruise more, and with this being a bleeding into the layers of the artery that came out of nowhere, I have a hard time saying you should be on a blood thinner.
Yep. So I would agree.
This came up recently on the SCAD Survivors Facebook page. Those of us that have had SCAD were thought by some to have coronary artery disease. Do we have coronary artery disease if we had no risk factors?
Yes. So the question is SCAD, coronary artery disease. So technically, yes, it is a disease of your coronary artery. So I think that, you can parse words, but people have said, do I have heart disease? Well, yeah, if you've had a heart attack, that's heart disease. But some people use coronary disease and heart disease as shortcut for the most common type, which is atherosclerosis. So you do not have that. So I think it's a more nuanced conversation, but I think I wouldn't want people walking out of here who had a SCAD to say, I don't have heart disease or I don't have coronary disease. It actually is a disease or a condition that affected your coronary, but it isn't the coronary disease. It's also, people who use that in lay terms is almost a shortcut. I mean, would you?
I totally agree, and I always tell my patients that yes, you have coronary artery disease, but make sure you then say, but it's SCAD, it's not atherosclerosis, because every doctor, if you say coronary artery disease, automatically thinks plaque.
Right. So it's going to be the default because it's the most common. And the other thing is I say don't say SCAD the first thing. I've had so many patients, can you believe they didn't even know what SCAD was? Well, if you Google SCAD, you get the South Carolina Arts and Design. So no, seriously, that's the number one.
Awesome.
And so what I would say is, and particularly maybe cardiologists will know it, but this is a relatively recent acronym. Your internist, your OB-GYN is not, say the word out the first time. Spontaneous coronary artery dissection. I had a tear in my coronary artery. It's SCAD. I think that's for you, your benefit as well. And don't give them such a hard time if they don't know what SCAD is, particularly if like they had a kid. No, I had a friend whose son went to there and she had this water bottle from the school that said SCAD. I so wanted one, but they changed the design by the time I went to the school store.
That's hilarious.
Is there a question?
Yeah, there's a few questions online. So Rob says, I had a carotid ultrasound to rule out FMD. Is that adequate? Is femoral ultrasound more common and or better?
The answer, so the question, this is a good question, is what screening tests for other vascular diseases are adequate enough for FMD and other conditions? So ultrasound is not inadequate in any of the vessels. Ultrasound can tell us if you have a dissection or an aneurysm, but it is not sensitive enough. It is not the test of choice for FMD. It also doesn't look at the brain. So the next level down, so MRI is not as sensitive for FMD compared to CT angiography. The gold standard is angiography. We're not going to go sticking catheters in and re-look. So in general, what most will do, and we have a protocol on a very low dose CT where we do neck, brain, abdomen, and pelvis. We skip the chest. We used to do the chest. It's extra dye. What we found is most people with SCAD had already at some point had a CT angiogram of their chest to rule out a dissection, so we can look at that. And that's going to rule out the important findings that may need treatment, such as visceral dissection, so dissections in your splenic artery, or carotid dissections with the least dye, least radiograph, and it's a one-time thing. So, but the question is ultrasound good? And if you had a clean ultrasound, they said confidently you don't have FMD, that's insufficient, because actually CT is not sufficient to rule it out. But we can rule out the bad FMD or the complications.
I might just quick add. So we got our protocol for doing the CTA from you guys. I don't know if you knew that, but no. I called your radiologist so that we could get it. And if you guys happen to be at centers where they're being proactive and they're interested in learning, mimicking these protocols.
Share.
Yeah, I mean, I think, well, yeah. Did you know you're there? Yeah. But mimicking.
Stanford, but I knew I've shared it with other people.
Yeah, no, I think, and because it's a low radiation and that sort of thing, I think it's helpful to get this going in other places too.
Yeah, I mean, the nice thing about this, what we do, and now you, is that it's a single test, because it used to we do, head and neck, and then the next, they'd have to go to a different machine. So we now do it once, and we do it one sitting, arms up, arms down, and we've done four vascular beds, essentially. Pardon? Well, it's a CT angiogram, but it's more the protocol. But you could still get a good study by just getting a head and neck. But it is, I know a lot of women are concerned about, well, not just women, but men too, but a lot of women are concerned about radiation. And I would just say, go to get on the machine at wherever you are, where they have the lowest, they have high techniques, they're not using too much dye. You can get some really great imaging currently for a little more than radiation than we did chest x-rays 5 years ago. And it's just getting better. Yep.
I'm talking to several people today who've all been treated differently and been given different advice. One of the things that kept coming up was rapid elevation in heart rate. I'm extremely active, I play a lot of sports, and I was told I have 2 cardiologists, one at Cedars and one in my challenge. I have no restrictions except for a rapid elevation of heart rate in terms of going from resting to, say, 140, 150 in a sprint. Because the shearing stress. Can you talk a little bit about the shearing stress? And we do have to go through surgery. So the shearing stress that happens with a rapid elevation in heart rate and blood pressure.
Okay, the question for those online is recommendations for rapid elevation of heart rate when one is accelerating and exercising, and particularly as it related to shear stress. And for those of you, shear stress is, if you think about it, it's the stress of the sort of the blood vessels or the stress on the artery. And it is one hypothesis. It is shear stress or increased shear stress may lead to weakness in an artery and causing it to split. So that's your question. I'll let you start. And I have an opinion on this, and because I think the bottom line is there's zero data.
Yeah.
There is zero data to tell you shouldn't get your heart rate up very fast, right. Or go on a roller coaster, or many of other things. And so we doctors like to treat ourselves by giving, because we don't know why this happened to you, so there's a certain amount of cautiousness that can happen. So shear stress may or may not be involved in SCAD.
So the viewpoint of shear stress comes from aortic dissection.
Big arteries.
So the big main vessel that feeds everything, and there's concern with that. Certainly if you already have a tear, that shear stress will make it worse. And we know like beta blockers help in aortic dissection, and lowering blood pressure helps in aortic dissection. And so people have transferred that to the coronaries, but we're not necessarily seeing that same thing. And as many of you know, a lot of SCAD patients were very physically active before. They're healthy people, and they didn't have a dissection, right? And they did this stuff for years, and they climbed mountains, and they rode roller coasters and all of that. So it is very hard to say shear stress is the problem. At the same time, there's a small number of people that it did happen at least during some extreme physical activity or acceleration in heart rate. So I agree. I think we can't really give great guidelines about that. I tend to tell my patients, at least moderate exercise, because we want people to exercise. We want them to at least reach the minimum guidelines for preventing atherosclerotic disease, because heaven forbid you develop atherosclerosis.
We want you to live long enough to be at risk for that.
Yes, exactly. And I have some people that if they really want to, they were planning on hiking whatever the tallest mountain in the world or something, then we have a discussion, and there's risks, but I can't totally say it's out of the question either.
No, but I think this speaks to a bigger issue on arbitrary limits that are set by cardiac rehab professionals, by physicians, by others. I mean, being told, oh, you can't ever lift anything more than 10 pounds. I mean, that is still very common. Well, so you peripartum and your baby at 6 weeks is 10 pounds, and what do you do? There's no data whatsoever. And so I think that's where this research, at least being able to share, maybe not with clinical trials, but say, at our rehab, we do high intensity interval training as part of cardiac rehab for everyone, not just SCAD. Old people, you can be 85, you can have SCAD, and we do Tai Chi too. So we've got, as we go through this, we are more cautious if somebody actually had their SCAD with physical activity. I'd be more likely to use a beta blocker on those folks. But again, I think when I sometimes hear people who are told these arbitrary limits and they're not having symptoms, I do worry a little bit that this is just that. It's a fear or concern or extrapolation of data from a completely different condition.
I'm going to just add that as we all get together more often and there's this collective expertise, I'm hoping that we can, and your paper does a nice job, but start to lay out guidelines that at least come from expert consensus, as opposed to somebody being like, maybe you shouldn't do this, and limiting your life in a way that maybe isn't necessary.
Yeah. Let's see. Take one in the back.
I know you talked a lot about pregnancy and hormones during pregnancy, but I'm wondering, is there any studies on, I'm well beyond pregnancy age, but mid-50s, going through menopause, and if you're on hormone replacement therapy, are there any studies to be concerned about that? We won't discuss those.
So there's no prospective studies right now in SCAD and postmenopausal hormone therapy. It is one of the most common questions I get, even people who are a decade from menopause age, because they've had the SCAD and they say, well, what am I going to do then? Well, if you think about how the changes in how we even prescribe hormone therapies to anybody have changed in the past decade, I say, stop worrying about that now. There may be some different things. I am cautious, and again, this is extrapolating. I'll be the first to say that. I would prefer that SCAD patients after SCAD not add any extra hormones to their bodies in general, because we don't understand those effects. That said, even, one could argue that somebody who has an atherosclerotic heart attack, even less should be put on hormone therapy after menopause. And in many cases, I think it's appropriate, with appropriate risk, antiplatelets, because it becomes a quality of life and a risk benefit. So in general, we look for non-hormonal ways to do that. But again, I don't think it ever means you can never do that, because, people don't sleep, they can't function. Some people really can. Now, do we have one from online?
We do. We actually have several that kind of go in line with what you're asking. We go back through this a little bit. I think you already addressed this, but I just want to make sure they get brought up. So Sinead said, is there any information about how much weight can be lifted? And then, sorry, let me find that. Oh, Elizabeth asked, as a SCAD survivor, are there exercise guidelines for long-term? I'm 5 years post-SCAD, heart rate, blood pressure, running, etc. I think you guys pretty much addressed that already.
No, but we can. So what I tell patients, and again, we don't have a lot of data, it is sort of expert consensus, but I say avoid competitive, high intensity, prolonged, things that lead somebody to be extremely fatigued at the end of it, bodybuilding, things where you're going to have to strain. So I don't give a weight limit, because what somebody can easily lift and somebody, so if it's a skinny little petite person whose straining would be 25 pounds, or that would be the limit, I said, that's probably, lift what you can without straining. I might have another woman who can easily lift 40 pounds without straining. I'm not going to put that same, so I don't give the weight limit. I say, how are you feeling? You breathe through it. Somebody says, can I run a 10K? I said, yeah, I'd prefer you didn't race a 10K. Let's not be trying to get personal bests, but go back, because I think because what I want, my goal for SCAD patients is to live the life that they want to live and be safe. And that does not entail putting artificial restraints on what they can do that have no basis in data. What do you tell patients?
I totally agree with you. I tell them very similarly, and I think the fact that we did a 5K walk run today maybe rings true to exactly what we're saying, right? We want people to be out exercising and doing healthy things for their heart, and we don't want to live in fear and restrict ourselves in inappropriate ways or unnecessary ways.
The lady under the clock.
I think ultimately the answer is probably that you don't know, so I guess I'm asking what you would do as a parent. As our girls or daughters get towards the, don't like to think about like the sexually active age, would you, if you were a SCAD survivor, avoid hormonal birth control and have them be using non-hormonal or hormonal?
So I'll repeat the question. So the question is in children, so daughters of SCAD patients who are getting into reproductive age in terms of their choices of hormones.
Right.
I actually get this question a lot, and I think that to me, the risk of a pregnancy is far greater than the risk of any, and not just because of who wants a teenage pregnancy, but honestly, the physical risks of pregnancy are much greater. And so looking at, and because the inheritance part is really weak. I mean, it's probably really uncommon that I would want, that next generation, I would not, at least now, make health decisions for them based on the mom's history. And so if it's the most effective way to keep a 16-year-old not having a baby is contraceptives, I would say yes. Yeah. I mean, that's, but that's not with a lot of data. But again, I don't think there's any reason for us to jump to the conclusion that we need to be treating this next generation in a kind of different way based on the genetics, the little bit of genetics that we have.
Agree.
Yeah.
I have a question about the correct use of nitroglycerin. I think I always thought about it as, like if you really get to that point, you have to do this like the emergency item. Which I've seen some other people where they kind of use it prophylactically. And then my concern about using it prophylactically will it not work for you in emergency situations? How do you properly use it?
So the question is proper use of nitroglycerin.
I do nitro all the time, so. I'm a big fan. So nitroglycerin, it has this kind of, there's a concept that it's only in the I'm dying sort of thing. And it turns out nitroglycerin is very helpful for chest pain. And like I said, I take care of all sorts of people that have chronic chest pain, normal coronaries, and nitroglycerin can be very helpful for them. And so I actually give a lot of liberal use of nitro and let people pick what they need, because people actually know, if I take this, it helps. If I take this before I work out, it helps. And so I don't see any reason that people should be suffering when they could take their nitro and it would help. You don't develop tolerance to simply taking sublingual nitroglycerin, so it's not that if you took, even several a week, but then something bad happens that it's not going to work for you. And I have people that take it several times a week. Usually at that point, we're going to be talking about a longer term one. The tolerance comes when you're basically on it 24 hours a day. And so you need a little bit of a holiday so that you don't get this tolerance. Some people can't. They need it actually 24 hours a day. And over the years, we do find that we might have to up their dose because they've developed some tolerance. So I say if your nitro helps, use your nitro. Don't think of it as only in an emergency. Take care of your chest discomfort now and move on.
Hi, you showed a slide that had an artery that was affected and then a healed artery, and I've been curious about what it
So the question is about the healing. How does that actually happen? And although we don't know the timing and who heals, because that would take a prospective doing angiograms or CTs on a regular basis on a lot of people. But we've done a lot of angiograms on people after SCAD that we looked at the artery that had SCAD, a year ago, and it's completely healed. You could not tell. You can't even tell with an ultrasound. So we also know that people who've gotten emergency bypass operations, we go back and maybe 5 years later, their bypass has closed down because their artery now has normal flow through it. So we don't know how quickly it occurs. In many people, it has occurred within a month, or at least partial healing. So we know this just from people who got imaging for other reasons and looked at it. So the healing can look like a pristine artery, which is another reason, if we can get by without using a stent and you can let the body heal itself and the patient not suffer, that's aside from the fact that it may cause more harm to put the stent in, is we give the body a chance to does that answer your question?
Yeah, but it can also just stay that way.
So there is no natural bypass, really. Like you don't grow new vessels around it.
No, new vessels, but say with heart damage is one that was being fed by the artery. Well, other arteries will compensate by adding more blood there.
Yeah, so we think most heal. Some never open again. Some that never open, there is a potential that you could develop what are called collaterals. But typically in the setting of a heart attack, if the whole vessel is closed, there's not going to be regrowth because that tissue dies within about 24 hours and the body has no reason to send it blood. The other thing we see is we'll see kind of a double lumen on some patients when they come back. And so they basically kept the flap, but there's flow going kind of in the true lumen and the false lumen and creating this kind of double lumen sort of effect.
In the red. Well, there's a lot of you in red. So.
In the red. Nice.
The red with the glasses on top of the hat. Okay. Yeah.
So I've had SCAD once. I don't want to ever have it again.
No problem.
I'm obviously here to tell a story, but you see all these high percentages of it happening again. You hear all these horror stories on the Facebook page. They've had it 17 times. And it's like, how can you even prevent it from not happening again? Obviously, it happened the first time. They're like, well, why would that happen? But I don't want it.
So I deliberately didn't spend a whole lot of time talking about recurrences because there's new data all the time, and let's talk about that. So the question for those online is talk a little bit more about recurrences. How often do they happen? Is there anything to prevent them or predict them? And I'll start by saying, yes, recurrences occur because some people were told at the time of their SCAD they never have to worry about it. So So I think that's one thing. But the vast majority of people never have another one. Okay? I think that's the thing to take away, and you must live your life as if you will not. Yes. Yeah. But some people don't, and I think that to start with that, what has been the sort of statistics, and again, this is from Mayo Clinic in Vancouver, where we're a referral center. So if you, as I said, if you had a SCAD in a community hospital and never had another problem, you didn't go to Mayo Clinic. But if you had 2 or 3, maybe you came to Mayo Clinic. So again, this may be, but at several studies looking over time, it appears that over a 10-year period, there's probably about a 20% risk of having another SCAD. And some people will have, I've not heard of 17. I've seen people with, but I have seen documented up to 5. Now those individuals tend to have very small heart attacks each time. Most of them have normal heart pumping function. So as scary as it is, they tend to be a new coming in with a little distal vessel, small vessel. So I think the way to look at it is acknowledge the fear and acknowledge the concern, because it's not 20% every year. It's like 2% every year over a 10-year period. It does happen. And we don't have anything right now that can prevent it. Okay.
There's the other one in red.
Where are we at that we have our gentlemen SCAD survivors, which I think is wonderful. I haven't had a chance to meet any of you guys yet, but where are we at as far as the percentages of where
Yeah, so the question is about men with SCAD. So actually men with SCAD, if you look at old data, they would say it's about 20 or 30% because they were including dissections that occurred because there was a plaque rupture. So they had atherosclerosis and they lumped them all in with non-atherosclerotic SCAD. So actually the percentage of men that we think, based on data, is probably lower than previous, because if we take out those who had plaque, it's less common. My estimate is it probably makes up about 10% of SCAD. Our research doesn't reflect that. We've actually got less in our, and so that's where you can help and spread the word, because, you know, as Dr. Tremmel said, you got to study both genders in order to get the full picture, and so that we can treat everyone. In the few that we have, what we've noticed is there is a little bit different, obviously there's not peripartum in men.
Very astute, doctor.
And this is anecdote because there's so few, but there's a higher report of men having SCAD during high levels of physical activity and bodybuilding, and some that have been associated with metabolic hormones, but most not. So I think it's a great question, and it's a way for us to continue to, when you see or hear and have it, or your physicians, is like, that's an area, and I said this before, it is ironic that I have spent the past 25 years complaining because they're not doing enough research on women and including women in clinical trials, and I am running a registry that is under populated by men. So we need to change that.
Yeah, I mean, the fact that we see, 42-year-old women and think that they have atherosclerosis when it's SCAD, you can imagine the men are completely not getting misdiagnosed.
Yeah. Yeah.
Mine's pretty specific. I know that most of us do have heart attacks, and some of us don't, whether that's from having lateral arteries or whatever. But I haven't yet had anybody else that hasn't had a heart bump, even after multiple tests, multiple visits to the ER. So even though the recurrence is probably not likely, how do I know to get somebody to listen to my people and
So the question is, SCAD without a troponin bump or without a heart attack, how common is it, or what is? So my experience in talking to a lot of patients who, often the troponin is not elevated at this when people first go in, and often that's the only one they get, that's the only attention they get if they're a young woman. They don't get sent, they get sent out. So in some of these, we do know that they can have stuttering, so they have a dissection, and the troponin bump may have been a week ago, and that we missed it.
What have you been in twice within that and everything?
Yeah, so I don't know, and I don't know how your SCAD was diagnosed. It is theoretically you can have a dissection and not cause any abnormal flow, and therefore no heart damage. But your troponin is very specific for heart muscles dying. So that would mean it would mean no heart attack then when they checked it, or heart attack but missed it, right, because of the timing of it. So, I think that's a very specific question. It does happen, but I think most of the cases that we have in our research is they were having symptoms for a bit of time and probably it got missed.
Yeah, it's also a general question, because women, well, and men, but have chest pain and go into ERs, and it's like, is this a problem or not? And I think it's at least reassuring if they check a troponin and everything looks fine, that there's not something bad happening at that time. That doesn't mean it's not going to happen in 2 days or 3 days. And so we always tell our patients you have to be aware, right? You don't want to live in fear, but you have to be aware, and you have to advocate for yourself, right? So if you go into an ER and they're like, well, gosh, you were here 2 days ago and your troponin was normal, but you're worried about it, then you get a troponin again, by God, right? And you say, I don't care, I want this done, I want to make sure that my heart's okay. So I think in a general sense that's important. But if troponin's negative and it stays negative, that's very reassuring, that nothing terrible is happening, even if it feels terrible.
But the SCAD was diagnosed 8 days later, having happened.
Right, so you are kind of starting to have, we don't know what that early thing is, right, in retrospect. So I think, again, it's in the moment, can we figure out the diagnosis? And coming in, chest pain is so common. It's like 10 million Americans have angina and chest pain. So simply coming in with chest pain, unfortunately, if nothing bad's happening at that moment, we can't say what's going to happen in 8 weeks. And I think the medical system's frustrating in that regard for people like you, certainly. But there's not necessarily a better way to do that.
So I'm mindful of the time because Dr. Tremmel has a flight. So maybe we'll take a couple of more questions. Do we have any that are...
We got a ton online. I'll try to get to a couple of them here. I know, they didn't make it, but...
Is there like a theme? We'll take one and then we'll get a...
There's something that's nice here. There's actually, Paula's online all the way from the UK, so I need to address Paula.
Okay.
And Paula and Christy both had a similar, more of a statement, because you addressed it early, which they both say, myself and my sister both had a SCAD event, so maybe there's more possibility for research there, but you addressed that early.
I would love to have their DNA and their parents if they are alive.
And then Christy also asked, is there an approximate timeline on when the statement from the American Heart Association might be out?
So no, Dr. Tremmel,
As soon as I get my review done.
So these just so you know the process. So it's been submitted. It's under review. It comes back because the reviewers always say something's not clear. We don't agree. We want you to rewrite this. We want you to add something, take something away, and so that will. And then there's a publication aspect. So it would be months. Would be I think just not years, but months.
You want to?
Yeah.
I have a question about the rehab and healing process. And possibly bringing in like alternative complementary healing methods like acupuncture, Chinese medicine, massage. What about supplements of herbs? We can strengthen maybe the artery walls and calm the micro vessels down. Have you had any results?
So the question is, in the healing process, are there other things other than or complementary to cardiac rehab, like supplements, herbs, acupuncture, complementary medicine, massage? So I am all for things that make you feel better. And if but there isn't any evidence that acupuncture helps heal a heart attack or anything. But if it makes your brain feel and your psychology feel better, or massage, I think self-care is not selfish, particularly after a heart attack. And so all of those things. I am concerned about the use of supplements, largely because often they may interact with the medication, your prescription medications, and we know less about them, and we certainly don't know anything about them in SCAD. So, but in terms of some of those other things that are holistic and healing and mind-body, I'm a big fan of getting in touch, mindfulness-based meditation, and all of those. But I think it's important to know those are not shown to have benefits specifically for the heart. They are for the mind and the whole body.
Agree.
Yeah. I mean, we do Tai Chi in our research, in our rehab. A lot of folks are doing other things, and we think that they're very beneficial to patients. Yep.
I have a question about the mechanism of FMD. Is it known whether it's a thinning or a weakening? What causes the dissection?
Yeah, so the question is about the mechanism of dissection with FMD. And I think it's important that although we think there may be FMD in coronary arteries, she has to see if her Uber's here.
It's arriving soon.
It's en route. So FMD is a condition that we've known about for decades, and we've known for decades it's associated with dissections and aneurysms. So it's what looks like a thickening of the muscle layer. If you look at the artery, a thickening of the muscle layer, but it's also a weakening of it, and I think that it has more stress on it because of the lumpy, bumpy part. So it's and we don't look at this in the coronaries, but if you look at it in the femoral arteries. Okay, we got to.
I hate to talk and leave.
Dr. Tremmel has to leave and we're sorry. I know this is fun. We'll be in touch.
I know. Right on.
So when we look at the artery, the muscles are not aligned. They're not proper, so they cause stress in the arteries. The challenge is we think that maybe there's FMD affecting the the coronary arteries. That's what Dr. Saw thinks she can diagnose it with an angiogram. But there's actually, even among pathologists, and remember, you have to be dead for us to look at the pathology in the coronary artery by definition. There's very little specimens, which is a good thing. It's moving, so we can't get the same kind of vision of it, and they're smaller compared to your femoral artery or your carotid artery. So we just don't know for sure, and that's why I'm very cautious about saying whether it causes it or not. But one hypothesis, and one that I'm pretty strong on, is the person with FMD and other blood vessels probably had FMD in their coronary arteries, which, since we've known for decades that people with FMD have more dissections and aneurysms, that may put them at risk. Do we have anything else online that's important, since I don't...
This one could be important, so just...
They're all important.
They're all
But I mean, as a last...
Cardiologists will not say whether or not my STEMI was due to a SCAD, and is aloof about diagnosis. How important is it to get the proper diagnosis? I'm 35, been no risk factor in the family history.
So I think that's a great last question. Yeah. Honestly, what a great question to say. So you saw at the very beginning, I said having a proper diagnosis is critical. And even if we don't know exactly what to do with SCAD patients now, knowing what you have and whether is going to help you down the line, potentially. Sometimes I can't tell. They have just a little bit of plaque, but at least not in the area that, and I think, well, probably SCAD, but they got a little plaque. So I want to cover both bases. I'm going to put that person on a stat, and I'm going to make sure I'm preventing atherosclerosis. You know, some of the, 65-year-olds, if you're 65, you may have a little plaque somewhere, but even though you had a SCAD. But the thing that I would say, if you've got a doctor that's termed aloof, evasive, can't talk to you, doesn't respect you, doesn't listen to you, derides you, makes you feel stupid, find another doctor. Get a second opinion, because I think there are enough cardiologists out there, and they're not all experts in SCAD, but a good internist who listens and hears you is better than 5 cardiologists, because they'll get you to a cardiologist. So my answer is empowering you, and don't settle. You're here, you're not settling. Right?
It's your heart.
Yep, it's your heart. All right.